Thank you very much for your introduction. The format is unusual, but I'm very grateful for the invitation to take part in this conference. I listened to the ideologies of this forum in the morning. I will just say
I would like to give some examples. I totally agree with what was said. Currently, clinical guidelines are taking new position and they're becoming more important. And it's becoming universal total approach, and this is a great standard of care. So it is related with the patient journey,
принципами размещения пациентов и так далее. То есть здесь связаны много деньги, материально-технические ценности, скажем так, наличие специалистов и все остальное. Поэтому мне кажется, что, конечно, вот то, что последние годы делается...
This is something which is done on behalf of the Ministry of Health, and now it's introduced quite directly. So this is a common platform that allows us to be on the same common platform. So that means we can stick to baseline requirements in the specific indication. We are creating the situation which could be very useful for the patients. And then it depends on individual experience. And let me remind you, so there are some classical requirements for those who are making the guidelines. So any clinical guideline where we can include this guideline to speak about the efficacy and safety. When we speak about drug treatments that have, state authorization, which are legal for the local healthcare, it could be the situation when we talk about the fact that all conclusions, all logical conclusions on using these or that methods of treatment, they're based on the principle of evidence-based medicine. And here we have traditionally particular volume of previous medical history. So that means studies and actually something which is randomized, very frequently placebo-controlled. And if there are several studies here, and if there is meta-analysis, then definitely we are getting the best quality of guidelines, and we're getting the most reliable positions for that. Then definitely we should label each guideline with a particular level of evidence and class of evidence, which is important. So to us, for clinicians, it could mean how solid is the characteristic of this recommendation about the efficacy and safety and the applicability in the clinical practice, whether we should stick to that. We understand that all that is done on the common approach and common scale, which is assessing the strength of the guidelines. And definitely, of course, these guidelines should reflect two positions, whether we can do it or we cannot do it. And definitely, this is very important. Due to that, it means that the modern methodology in the global medicine is the methodology of evidence-based medicine. So that's exactly I just talked about. So here you see randomized clinical trials, and we can be based on some particular experience and recommend some type of care as a main treatment. And the real clinical practice, either in the evidence-based practice or routine practice of using these or those technologies, this is alternative methodology. And in the ideal option, it should have some less sense, and it may not be as supported as RCT or, let's say, clinical trials, which are in the basis of the clinical guidelines. inevitably. So looking at the current realities and looking at the fact that not all methods of treatment are massive and not in the big cohort of patients. So there are groups of the diseases, so-called orphan diseases, where the population of patients is not very high. So to get some massive data there that could be, compared within clinical trials, typical standard clinical trials for the evidence base of medicine. This is something that could be used as a tradition of treatment, let's say in this territory or in this country specifically. And so here are the ways to be used. So here we can assess the experience looking back. So it looks like if we try to grade it, so these are interventions and proper follow-up. So there are some observational studies and there is some objective response, but they were organized as a randomized operational trials. Or it could be comparative studies in the cohorts, or let's say cross-functional case control. And in this context, it could be a very different rate of significance, but still they deserve some discussion. And due to that, there should be a very differentiated approach from the position of creating of this classical assessment to what extent it could be convincing and there would be high rate of evidence. Speaking about the technology of collecting the information and collecting the data that could be in the basis of clinical guidelines, there is some group of data which is accumulating around some indication, and this data for this period of time it could be a very good source for the analysis to analyze the efficacy and safety as it happens in the real clinical practice. And the source for this database could be results of patients follow-up, or it could be the results of some clinical trials. It could be electronic database of the hospital or outpatient clinics, insurance companies, and regional registers. So it could be value to assess the methods, to assess the programs that were used. And in this context, and there will be enough resources and the use of these and those technologies of statistical processing, it could be the use of additional resources for the collection of this data. All that can strengthen the value of these databases. The second important thing is definitely the critical approach to the information that we get as a result of accumulation of data in the real clinical practice. And here we need to understand that all aspects should be included. So on the one hand, we should assess the source of data, where this data comes from. So primary use of data, for example, observational perspective studies, where from beginning to an end, we had some patient reviews and also follow-ups for the pool of the patients which go for the treatment. Or it could be secondary use, where retrospectively we assess some databases that were accumulated before. On the other hand, we should assess it for the outcomes, clinical effects, economical effects. So these are results of patient's assessment.
Конечно, важно, когда мы оцениваем или анализируем.
It's important when we assess or we analyze the results of the studies based on real clinical practice, how the process was organized. Because in this case, one thing, so it could be post-factum data from the databases, or it is still organized and followed up in the process of the treatment. And this is average about the efficacy and safety and some changes of the quality of life. And summing up, in the previous positions, we can make a conclusion about the evidence-based evidence. And we will see how the design could influence our scale that we are using in terms of strength of the recommendation. Well, traditionally, we understand that the, let's say, the highest level of evidence base, and that would be only in the randomized clinical trials. And we understand that the real clinical practice has less high level, but still less high level of evidence, but still it can be used also within the scales. So this is a position of the treatment program or rehab program. And we understand that it would be within a range of conditional recommendation or weak recommendation, but still there is a particular level and particular task to do that. And again, according to that, we can simply continue. And the level of recommendation would not be very high and would not be ideal, but nevertheless it is very valuable because in this particular case, it closes particular gaps. And here we see the following positions. So still, the value of the real clinical practice when you put guidelines could show the efficacy in the real therapeutical issue due to the reality of the medical care, how it's organized in the region, in the outpatient centers, etc. We understand it can be a particular compromise, understanding that in routine practice, doctors don't always follow to the complete amount of recommendations and medical guides. So it's not always optimal, or let's say as a result of professional level or training of preparation, or maybe due to the financial issues. So there is some access there, but nevertheless, the program is performed and what the results are there. So it can also be taken and then we can make conclusions on how effective this treatment could be, even if you don't fully follow the guides. Then I think it's the most relevant for the Russian Federation, especially when we see the lower compliance of the patients. Still, at least in a short-term perspective, we could see that the real effect is there, the real effect from the treatment programs. And as I said before, so very frequently, you also can use the experience of the real clinical practice where it is not possible to use long-term and very expensive, properly organized clinical trials, so where you cannot organize it or you cannot expect very fast results to use it later on. So because the average time for the real clinical practice effect is 1.5 to 2 years, and some RCTs, the average duration from 2 to 6 years, So definitely in this case, if there is a need to implement the technology earlier, and if there is a clear need, let's say, to provide care to the patients here and now, definitely we can be based on the real clinical practice data. And the story here, the story of evidence-based medicine is shorter than the history of medicine in general. And the history of using of particular treatments in the real practice definitely is much bigger, and it matters, and it has particular value. As an example, I want to provide you the following logic and the following guides that actually we could identify based on real clinical practice, and then particular expert conclusions for the future. So what we can do, let's say, here and now. For example, there is a guide. I apologize. We are behind the schedule strongly. Oh, yes, I got it. So it is recommended to the patients to carry out assessment by Glasgow and by 4, and it appears to be that we have a very low level here, because actually the study was not organized this way to have a very wide population by the age, and also the standards, clinical standards, were not identified, and definitely a reflection of the data was not standardized, and the period of time was very long. So then there was no verification, subjective verification. This is how it became possible with particular limitations for patients in a conscious state. And then we can use these scales. The other guide is for the treatment, where we say that we mean the use of antithrombotic treatment within 24 hours after the introduction of fibrinolytics. So that means in this case, it carries some risks. And there are studies that tell us this risk is not very high and you can use it. So there are some methodological errors that could give us a pretty high level of evidence and good level of confirmation. So this is an example where you can introduce it, but nevertheless, it helps. It helps, although this is a weak recommendation, it helps us to support more patients. So there are several positions here. The quality of information in the practical healthcare, where we need the position not of one person only, but let's say the position of all the doctors. And these are advisory boards. For example, if we look at the recommendations to patients to carry out treatment with statins, ezetimibe, and PCSK9 inhibitors to reach target level of cholesterol, is a high level of evidence, but it mentions just particular positions without touching the whole group of drugs, and this is how it is extending the group due to the add of new and modern treatments from the group which is introducing into the synthesis of PCSK9, and then here we can hope that they would be acting very effectively, as well as the inhibitors of this enzyme. So it appears to be that we can use those clinical trials, randomized clinical trials data, where among others, so that means multi-stenotic process, cardiological, and let's say large vessels, plus ischemic strokes, and to the ischemic stroke. So we can add on here also another recommendation. So that means that advisory board that would analyze real clinical practice here could be the basis to introduce as a recommendation, clinical recommendation, 2 positions that it can be done in a high-risk group, and it should be done also where statin treatment is not effective. I am sorry, and I'm already wrapping up. So that's my final slide. So these are requirements to the clinical practice. So probably it should also be formulated properly. So it should reflect the issues of the efficacy and safety. So it should be around the proper treatments, and also it should be the use of statistical resource, which is valid for, let's say, all of us, and also it should be proper length to provide adequate